কি শুরু করবো?
Sir, can you hear me?
Okay. So welcome you all to this PGCME organized by KPC, and I think it would be an interesting one because KPC having lots of eminent faculties and also at least 6 PGDs are there per year, and I think this will be a live discussion and with the question answer session also. So with these few words, let us conclude the remarks and start the program. Arnab.
Yes, sir. Thank you, sir. So I, on behalf of West Bengal Orthopedic Association, I welcome you all. And I request Professor Nilay Kanti Das, if he is present, please tell few words and what will be the plan and what will be the cases. Then we start the cases.
Option on করে রেখেছে
Sharing the screen, please stop it now. Once we tell you, please start.
তোমার এটা জুম, এটা হচ্ছে তোমার পিপিটি, নরমাল পিপিটি ডাবল পিপিটি খুলে নিয়েছে। হ্যাঁ, ঠিক আছে, এবার তুমি জুম খোলো।
Please mute all. Ritik.
Yes.
So if Niloy sir is not there, could you please tell us the plan and what are the cases there?
Thank you. Good evening all. Basically, this is the second PG course on behalf of WBF platform. It is performed by KPC Medical College. There are basically 3 cases. First case will be the first 2 cases are the pediatric cases. One is proximal tibiofibular synostosis. Second case is basically a case presentation of a rare CAFES disease, and there is a third case also of this multi-ligament knee injury. So there is a sequence. First, we'll start with this proximal tibiofibular synostosis with the speaker is Dr. Kontio Ghosh, our third year PG. Kontio, please start your presentation.
Okay. Sir, am I audible?
Yes.
Okay. Sure. Very good evening to all my respected teachers. I am Kontio Ghosh, third year PGT from KPC MCH. So here is my case presentation. So a 13-year-old boy presented to our OPD, and his complaint that the parents brought him with was there was inward bending of both the knees and there was bilateral ankle pain. The inward bending of the knees was existing for the last 10 years and bilateral ankle pain for the last 6 to 7 years, and pain at the ankle, right ankle, was aggravated for the last 6 months. His birth history and developmental history was normal, and his milestones were achieved at the age which was within the expected time. Gradually, he developed inward bending of both of his knees, which is progressing gradually. There was pain at both the angles, which had started 3 to 4 years back, and now increasing for the last 6 months. So this is the picture. As we can see that the knees are touching each other. There is pronation of both the feet along with the outturning of the toes. Also, we can see that the left knee is slightly higher. There is a shortening in the left limb as well of about 2 centimeters. There was no wasting that was noted. And if I show this picture as well, there is heel valgus in both the heels, along with external rotation of the feet. And I think this is more appreciable from this angle. And this is the X-ray that was taken.
Before X-ray,
yes.
So what is your clinical diagnosis?
Sir, my clinical diagnosis is a 13-year-old boy with 17-degree bilateral bilateral genu valgum, which is idiopathic in nature and gradually progressive, along with bilateral ankle pain, which is worsening for the last 6 months.
He has had no knee pain ever?
No, sir, there is no knee pain.
So, but basically, your diagnosis means there must be some history, name of the disease, is it not? Of the deformity. So, you are going to present a short case, isn't it?
Yes, sir.
So, in short case, what is the style of presenting the diagnosis? first you have to tell the presentation, what is the presenting problem, then the root, what is the cause behind it, next the duration, next the side of this unilateral or bilateral, next identify the patient. That is the usually the style of telling the diagnosis. So basically it is a case of that is a genu valgum, bilateral genu
Bilateral genu
valgum
valgum. Yes, sir.
with some secondary deformity of the ankle, isn't it?
Yes.
Secondary
Yes, sir.
deformity of the foot and ankle. That is, what are the deformities of the foot and ankle? Can you please summing up?
Yes, sir. So there is heel valgus, there is pronation of both the feet as well as external rotation.
Pronation of both the feet means which type, which part of the feet? It is whole of the feet, or it is a forefoot is pronated, hind foot is different, or like that. So you have to mention here. Do you
Yes,
understand?
sir, the whole foot is pronated.
Pronated, yes.
Yes, sir.
So there is a here valgus heel, pronated whole foot, and any other abnormality?
Yes, sir. Externally rotated.
Externally rotated. Which part is externally rotated?
Is there any external rotation of the tibial shaft, or you think the external rotation is basically around the ankle?
Yes, sir, around the ankle.
So around the ankle, if
everted, I would say everted.
You don't call that external rotation. You call that eversion.
Eversion.
Yes. External rotation is different. So it is a bilateral genu valgum deformity with secondary. It may be ankle deformity, maybe secondary to genu valgum, isn't it?
Yes, sir.
Maybe possibly it is a secondary
to genu valgum
and pronation deformity of the whole foot, bilateral. Most probably idiopathic. It is progressive and symptomatic in a what is the age?
Sir, 13-year-old. 13
years old girl. Boy.
Sir, boy. Yes, sir.
Boy. Okay, fine. So this is your complete diagnosis.
Yes,
now the examiner will ask one by
one.
Yes.
No, excuse me. I have to add two things. One is this looks preeminently a thing that may have some importance with sibling history. So it's looks something like congenital. So you have to have a sibling history, number one. And number two, it's very important to say something right from the beginning about the state of the hips. Because in these cases, the hips, the knees, and the ankles are very interrelated.
Yes, sir.
Won't you agree?
Yes, absolutely, sir.
Have you found any other deformity in other parts of the body?
Yes, sir. There were no other deformities in other parts of the body. There was no external, no external rotation or any.
Chinmada, please ask your question, Chinmada.
Or any other.
Anando,
yes, sir.
Yeah. So, what is the pronation of the foot? How will you define the pronation of the foot?
Yes, that will come. That one by one. Why genu valgum? Why heel valgus? Why pronation? So that will come one by one. So that's I'm taking the just usual rhythm of questions asked in the examination.
Yes.
And first, we have to tell the complete diagnosis. Then the examiner will ask one by one, why are telling this. What are the points in favor of genu valgum? What are the points in favor of heel valgus? What are the points in favor of pronation of the foot, as you mentioned? Then why not what are the differential diagnosis? Why not these different that may be a genu? Why not genu varum? Why not is a supination? Why not it is a that like one by one? Okay, so tell one by one. So why are telling we have asked Dr. Chinmada. So why you are telling it is a pronation of the foot?
No. My question is how you define the pronation of the foot?
Yes. Tell what is pronation? Okay. What is pronation of the foot?
So pronation of the foot is, eversion at the ankle with the medial border or the inner border of the foot having ground contact, and the foot rests on the thumb, the great toe and the inner border of the foot.
So
the medial border of the great toe.
It is the ankle deformity. You mean ankle deformity?
No, there is eversion at the ankle, and there is
eversion occurs at the ankle or somewhere else.
Oh, sorry. So eversion at the subtalar joint, along with abduction at the midfoot, and there is, the foot rests on the inner aspect of the great toe and the
Make your conception clear. Yes. Anatomically, foot is divided into three parts. Anatomically, that is the hind foot, midfoot, forefoot. But clinically, it is two parts. That is the hind foot and forefoot. So forefoot, the main movement occurs at the subtalar joint. Subtalar joint means it is the talocalcaneal and calcaneocuboid. So inversion and eversion at this level, and if you draw a line between the talonavicular and calcaneocuboid joint, the part beyond that line it is the forefoot. So pronation means it is the eversion of the hind foot and abduction
at the front.
Abduction of the forefoot. And the reverse, that is the adduction, that is the inversion and adduction of the clear.
Yes, sir.
So you must be clear when you are presenting this type of patient. You must be clear about the joints involved. Ankle joint, what are the movements occurring there? Subtalar joint, what are the movements occurring there? And metatarsal joint, that is what are the movements occurring there? And accordingly, you should define. Now you carry on.
Yes, sir.
So this is not that actually pronation occurs at the subtalar, not at the ankle. Okay. So why you are telling it is a cubitus genu valgum deformity?
Yes, sir. So genu valgum deformity, as we can see clinically, that both the knees are touching each other. And if we draw a line, that is the femorotibial alignment, that is a straight line joining the anterior superior iliac spine and the center of the patella, and another straight line from the center of patella to the center of the two malleoli, we can measure the angle. And the normal angle is 7 degrees of valgus. Here the patient has 17 degrees of valgus. This is clinically.
Also intermalleolar distance.
Yes, sir.
Ponteo,
Yes,
actually, it is the clinical diagnosis. Ask
Yes,
the patient to stand and ask the patient to touch the knees and malleoli. Just to touch, not to press. Just soft tissues to touch. If you normally, usually the medial side of the knees and malleoli touches in normal person. There may be maximum difference between 0.5 to 1 centimeter, which is accepted as normal. If the intermalleolar distance is more than 1 centimeter, it is the genu valgus, and intercondylar distance at the knee, if it is more than 1 centimeter, it is the genu varus. It is the clinical diagnosis, no need to draw the line, etc., etc. That is more advanced when you proceed further.
Okay, proceed then.
No, but Ananda sir, I think you have muted yourself.
Okay.
Hello.
Hello.
Yes, sir.
So basically, it is a very basic thing. So, who should don't tell. So suppose it is a why you tell this cubitus varus. My student starts to telling there is a key carrying angle. Don't tell that. So it is a basic, very anatomic, as Dr. Chinmay has highlighted. So basically, it is a anatomic. So start from the inspection. So on inspection, when the patient standing in anatomical position, with both the knees are touching with each other, and there is abnormal gap between the two malleoli. So that means it is both the legs are wide apart from the midline. That is basically this why it is a genu valgus. This is simple an answer. So you should not tell these TBO because it is not possible to draw this angle in clinical examination, isn't it? So we should not tell. So it is a genu valgum deformity. Next is a heel valgus. You have told it is a heel valgus. So which type of deformity it is? It is a pes valgus deformity. So how do know it is it? What is the method of examination of pes valgus? Method of examination of pes valgus deformity. You told it. You told just.
You are examining the heel from the back. What tells you it is? What tells you it is valgus or neutral or varus? You have to tell.
Dr. Ovijita, you have made your life simpler. So always try to stand from back.
Yes, sir. When we are seeing the patient from the back, we are seeing that the foot is deviated from the midline.
Not foot. What is the normal alignment? What is the normal? No, tell first what is the normal alignment of heel?
So normally there is normal valgus 0 to 2 degrees.
How do you know that? How do you know that it is normally aligned?
Oh, okay, sir. When we are standing with both the malleoli together, there is a lateral deviation of both the heels of the hind foot.
How far lateral deviation is acceptable? How far lateral deviation is normal? These are some parameters. It is written in the book. That is I'm asking. So I'm telling. So without questioning. So once the patient you examine from the back. So in anatomical position, if you draw a imaginary line along the tendo Achilles, and then the insertion of the tendo Achilles to the center of the heel, that both the line will make a line of 3 degree outward. That means the heel line is 3 degree valgus in respect to tendo Achilles line. Or tendo Achilles is relatively, if you take the line of tendo Achilles is extended down, that will remain inward than the point of the heel, point of the center of the heel. So that means heel is relatively out, the center of the heel is relatively outer in respect to the line of the tendo Achilles. So that is the normal alignment of the heel. Now see, this is much more abnormal. If you see from the back, the line of tendo Achilles is much more. See, on the back, if you center of the tendo Achilles is going down, it will directly come into the floor. So center heel is completely outward from the floor, from that line. So,
more than 15 degrees or 20 degrees maybe.
Yeah.
Even without zooming, you can make out.
Exactly. So if you ask to quantify, then you have to draw that line. Now you have to ask, if you clinically, if you ask to quantify that how much genu valgum is there or how much heel valgus is there, what would be your clinically? Remind it. So what is your clinical method?
Yes, sir. Sir, clinical, we can use the intermalleolar distance, and we can use the intercondylar distance as a clinical marker.
Okay. Now one by one. So intermalleolar distance. So yes, what is the method of examination of intermalleolar distance? How do you measure the intermalleolar distance?
Sir, with the patient standing and with as sir said, we cannot make the patient stand with the two medial malleoli touching each other, and with the standing erect with the patella facing forward, the intermalleolar distance here is 13 centimeters.
See, it is always would be examined in standing position, or it can also be examined
measured in supine position.
Supine position.
Tell that.
Yes,
so that is the complete. That will complete your statement.
Yes,
so
we can also.
Intermalleolar distance can be examined both in supine position and also in standing position.
Yes.
Why? What is the implication?
Yes, sir. So because when the patient is supine, we can make out whether there is external or internal torsion of the tibia, which can make our judgment, which can affect our judgment. And also there might be femoral anteversion or
No. You are mixing something else. No, there must be something different implication. Intermalleolar distance in supine and intermalleolar distance in standing. There are some different implication.
Can you think of something called joint laxity?
Yes, sir. Yes, sir. Joint laxity. If there is ligamentous laxity when the patient stands.
Which ligamentous laxity?
Sir, in this
in
patient.
In case of valgus.
Because it is gone valgus, so there must be medial joint line laxity. Because when the patient stands, the deformity will increase.
Yes. So that is you tell that. So sir, if we have examined the intermalleolar both in standing and supine, if it is in a standing intermalleolar distance is more than the supine, that indicates there is a possibility of
ligamentous laxity.
Now, how do you confirm that?
Yes, sir. Sir, if we have ligamentous laxity, we can either test. We can do two things. One is we can test the knee for ligamentous laxity by varus and valgus stress test. Also, there might be generalized ligamentous laxity, and we have to measure the Baton score.
Very good. So, have you examined that in this case?
Yes, sir. Yes, sir. We had measured, and there is no evidence of generalized ligamentous laxity.
There is no ligamentous laxity.
Yes, sir.
Okay. So, and is there in medial ligamentous laxity of the knee?
No, sir. That is also not.
Okay. Now, this is one method of estimating the quantification. There is another method of estimation, clinical method of estimation of quantification of genu valgum. Is there? Do you know that?
Mm-hmm.
What is anatomical line? What is anatomical axis?
Yes, sir. So the anatomical axis of any bone is the line along the mid diaphyseal axis, and the
What is the
mechanical.
anatomical axis of lower limb?
Yes, sir. The anatomical axis of lower limb, sir, it passes from the it passes along the mid diaphyseal axis of the femur from
How
the.
it can be drawn? How it
Yes, sir.
can? So there are two axes for the lower limb which are clinical important
Yes, sir.
of importance. One is the clinical importance is the anatomical laxity, and
Yes, sir.
radiological importance is the mechanical
axis.
mechanical axis. Anatomical axis and mechanical. Anatomical axis is drawn clinically, and mechanical axis is drawn radiologically.
Yes, sir.
So how will you draw it?
Sir, we join a straight line from the SIS joining the center of the patella and right up to the middle middle of the two malleoli.
Middle of the
two malleoli, I mean the intermalleolar point.
No. So actually the line anatomical axis is the line joined from the anterocerebellar spine to the center of the patella. If it drawn downwards, normally it will touch the medial malleolus.
Yes, sir.
That is the anatomical axis.
Yes,
but what happens in the genu valgum? So
yes,
that
sir.
medial malleolus will lie far away from that line, far away from that line. And what happens in the genu verum? So in that case, the medial malleolus will come inside that line.
Inside that
line. Means that line will fall somewhere between the two malleoli.
Yes, sir.
Okay. So that is basically the anatomical axis. Another clinical importance, which is not less significance, is the plumb line.
Yes,
plumb
sir.
line. So these are the three ways by which you quantify the genu valgum or genu verum deformity. In any panelist from any Abhijit or Chinmay, is any other point to be added for this?
No. All right.
No, I think it's adequate. Yeah.
So clinically it is fine. Now, what are the secondary deformity complex? If there any type of deformity around the knee, there may be some secondary deformity complex around the hip or around the ankle. As Dr. Abhijit rightly mentioned, always we have to search for some secondary deformity complex in the adjacent joints, because that will carry importance regarding your plan of management. So what are the secondary deformity complex you will search for in this case?
So as there is genu valgum, here I will search for deformities at the ankle, as there might be shortened lateral malleolus along with as here it is present heel valgus and the eversion of the foot. And as for the hip, there might be changes such as increased femoral anteversion or external rotation at the hip.
No, come one by one. So for the foot and ankle, you have told there is a heel valgus.
Yes, sir.
It may be either primary deformity or it may be secondary.
Secondary to the knee, yes, sir.
Secondary to the knee. So what is your opinion? Is it primary or secondary?
Sir, in our opinion, it was that secondary to the knee problem.
But we have told we have very significant information that is a lateral malleolus is short, isn't it?
Yes, sir.
So does it occur in a secondary deformity or primary deformity? What is the cause?
Sir, if the lateral malleolus is short, that is in cases of primary deformity.
Yes. So that is basically suppose, sir, when the secondary deformity usually develop? Because of the ligamentous laxity. So there must be possibility of generalized ligamentous laxity, which is not present in this.
Not present here.
So you have to suspect there must be some primary deformity associated with it. So you have already examined that lateral malleolus is short. It is very important information. So how to examine both the malleoli relationship of both the malleoli? What is the normal relationship?
Sir, I mean, we did not find the lateral malleolus short. I said that I would look for it, but we did not find it here.
Oh, so
no, I said.
What is the normal relationship? Tell first.
Oh, yes, sir. Sir, normally the lateral malleolus is, I mean, is being distal to the medial malleolus by 1 to 2 centimeters. It means to be lower than
1.25 centimeter below and
below the. Yes,
below and posterior. That is lateral malleolus is 1.1 centimeter below and posterior to the plane of posterior in the plane of in comparison to medial tip of medial malleolus. Now the examiner will ask, there are several questions will come. So how do you identify the tip of the medial malleolus? How do you examine the, how do you identify the tip of the lateral malleus? For the shortage of time, I'm not going into detail. And next, what is the alignment? That is intermalleolar lines, imaginary intermalleolar line. It is 15 degree externally rotated in comparison to the midline. Okay. So these are, so now the heel valgus, is it flexible or rigid? Now this is the question.
Okay, sir, this patient, it was flexible. It was not totally rigid, sir.
What is the other differential diagnosis of this pronated foot? What is the suspicion? So as that may be a congenital abnormality. So we have to suspect something abnormal in the foot.
Let's put it another way. You get a pronated foot and a pes valgus, and you're not going up. This is all you got. What is your differential diagnosis?
Sir, I would look if there is
not taking anything in the knee into account. Just give me the differential diagnosis.
Sir, if there is pronated foot and heel valgus.
Yes.
Okay. We might have to look for congenital vertical talus or associated problems.
And
tell the differential diagnosis. Okay, you are right. They tell
there
the
are
other
other things.
diagnosis.
Other significant diagnosis.
Yes.
Think of absence of some structure in the foot, in the leg.
Or weakness.
Weakness or absence of some structure, some bone.
Fibular hemimelia is
Yes,
one
sir.
cause.
Absolutely.
Yes, sir.
Once you have told some deformity, cause of the deformity, you can start with the anatomical structure.
Causes,
It
yes,
may be
sir.
osteogenic variety, it may be myogenic variety, or it may be
Neuromuscular.
idiopathic variety like that, neuromuscular deformity. Okay, so
Yes, sir.
so if you think in this manner, there are several causes we have. So what is osteogenic variety? There is one osteogenic variety you already told. That there is a tarsal coalition. That may be a possibility. Now, what is the myogenic cause? There is a peroneal muscular spasm. That may lead to this type of. So you have to think one by one, and you can tell. So have you examined the peroneal muscles and the inverter muscles?
Yes, sir.
So is it normal?
Yes, sir. There is no marked deformity, sir. There is no contracture of the peroneal muscles.
So all are working normally.
Yes, sir.
The muscle power.
Muscle power was also, sir. There was no, weakness associated.
What muscles did you test?
So since there is, eversion deformity, we have to test the peroneals if there is contracture. We have to test the gastrocnemius complex for plantar flexion, and also since it is pronated.
So is there an imbalance of muscle power around the ankle?
Yes, sir.
Yes.
Yes, sir.
Which imbalance? Tell that. It is a very important finding. Is the everters are much more working than the inverters?
Inverters.
Is it?
No, sir. We did not find that.
Oh, you did not find. So
yes,
there is no muscle imbalance.
No muscle imbalance was noted, sir.
Okay, so it may be some other causes, like maybe tarsal coalition, or it may be intrinsic muscle paralysis, and lead to this type of deformity. We have to examine the other intrinsic muscles of the foot, isn't it? Have you examined the intrinsic muscles?
No, sir. Clinically, we have not done that.
We have to examine this. We have to all the intrinsic muscles, especially the short muscles, and also the cart test. We have to examine the test, whether both the adduction of the toes are normal or not. Okay, and the inverter power, whether it is equal or not. This is most important.
Especially the muscles you can test individually, like the peronei, tibialis posterior, tibialis anterior. You have to test that, because if you are suggesting that you have, or if you're showing that there is a pes valgus, you have to explain it. Either as Ananda was saying, either as a osteogenic or congenital or a neuromuscular entity. So you have to, it goes without, it's a default thing that you have to say something about the muscle or its imbalance, right?
Yes, sir.
Okay, fine. So we have completed the examination. That is basically a venu valgum deformity, but it is asymptomatic. But the ankle is significantly valgus. And see, the right side is much more valgus than the left, and that is symptomatic.
Yes, sir.
symptomatic. So we have to address, isn't it? Now,
Yes.
how do you approach the case? Anything else? Any clinical examination is just to be done from the panelists or experts?
Yeah, I would suggest how do you examine whether you have a deviation in the anteversion of the hip.
Yeah, that is very important.
How do you test that?
Anteversion, how to measure the anteversion, normal anteversion present or not?
Sir, I mean, we would see, I mean, the plane of the retina.
Pardon? Okay, we have to see for the hip. We have to check whether there is a associated increased anteversion, or there is a genu-valgum deformity. There is a possibility of there is Coxa-Vara deformity also. We have to see. We have to rule out whether there is a Coxa-Vara deformity and the femoral anteversion in the hip. Okay.
Yes, sir.
Yes. What is the status of the patella and its stability? One question is there from Anirban. Anirban, are you in our panelist? You can directly question to the student also. What is the patella? Yes, the patella stability is you have to check it.
That's very important. Yes.
Yes, sir. So there was no patellar instability that was evident on clinical examination. And
okay. So so just summing up the case, this is basically, it is a genu-valgum asymptomatic, and there is a pes valgus deformity, and pronation deformity is much more on the right than the left, which is symptomatic in a growing child. And you have told it is a progressive deformity.
Yes, sir.
It is, yes. So this is a concern of, for treatment. Yeah, but there are no other other deformity, and there are some the secondary deformity complex is not very prominent in this case. Now, how do you approach the case?
So, since this is a growing child with increasing deformity, and the child is symptomatic, and the symptoms are also increasing, this child is warranting management. We cannot just see.
So what is just one question? Just one question.
Yes,
well, what is the difference between a progressive deformity and a non-progressive deformity, and what are the causes and its significance? That's just all.
Yes, sir. So in progressive deformity, there might be physeal problems at the knee, so that one physis, the lateral physis is not growing, and the medial physis is continuing its growth. And since it is continuing its growth, there will be deformities along with, there might be shortening as well as coronal plane deformities, and that needs addressing on its own merit. Otherwise,
yes, you are right. Now,
yes.
What are the causes of that progressive deformity?
Say it in solid terms. One is, if you have a progressive deformity at the knee, it is bound to affect the ankle sooner or later. Number one. Number two, you definitely will increase the medial laxity. In this case, medial laxity. Thirdly, at a later age, obviously there will be
osteoarthritic changes.
Osteoarthritic changes. Let's put it like chondrocytal. The cartilage problems will be there. So these will separate something which is permanent and not really progressing from a progressing thing.
Yes, sir.
Okay.
Yes. Then.
Okay, carry on. Next, what will you do?
Okay, sir. First of all, I would like to perform a radiological examination, including X-ray of the affected segments, as well as orthoscanogram or computed scanogram to have a whole limb. Yes, sir. I actually have this X-ray, just this X-ray present.
Okay.
Okay. Additionally, along with this, I would want a whole limb view, that is an orthoscanogram or a scanning computed tomography, so that we can assess the mechanical axis from the imaging as well, seeing that if there is any malalignment or malorientation at the knee, and we can assess it and then address that.
So the radiograph, read the radiograph. What is the abnormality?
Yes, sir. So in this radiographs, we can see that there is bilateral proximal tubulofibular synostosis, more marked on the left side.
So what happened in the inferior tibiofibular joint?
Yes, sir. Sir, in the inferior tubulofibular joint, there is, separation of the syndesmosis on the right side.
So what is the expected level of the malleoli?
The medial malleolus and lateral malleolus.
Yes, sir.
How do they normally lie, and
Yes,
what is
sir.
it in this particular case?
Sir, in this particular case, the medial malleolus is, the relationship has, it has
Now
gone
you have told
opposite.
the relationship is normal. So how can it be?
Not at all.
Sir, can you please repeat?
So how they see the radiograph,
Yes, sir.
see in the lateral view, how the lateral malleolus will be lower than you have told the lateral malleolus is lower as normal relationship in this case. But
Yes,
see
sir.
the radiograph is clearly shows the lateral malleolus is very higher up.
Much higher.
Yes,
Much higher.
And that is
So,
the bony cause.
that-
That is the bony cause of pes valgus deformity.
Pes valgus
Yes,
deformity along with the
Yes.
eversion. Yes,
no,
sir.
no, what is being asked is
Yes, sir.
that you were saying during the examination that they are at normal levels. So that is not true.
It is impossible, isn't it?
Yes, sir.
So now
It
can you
is a
tell how
pretty
now you have
significant difference.
Yes,
yes,
sir.
now you have to tell how will you identify the tip of the lateral malleolus. That is most important. Method of palpation of medial and lateral malleolus tip is very important. So that is why you miss that level.
Okay. Sir, we will identify the tendon of the peroneus brevis when we are everting the
No,
foot.
not from tendon, not from,
No,
from the
no.
lateral. You will come from the lateral or medial border of the sole of the foot. You go up and we have to find out what is the most important point, the most prominent and hard bony point on the lateral side is the lateral malleolus, and the medial side medial malleolus. And the point is medial malleolus, the tip of the medial malleolus, it is the junction between the posterior and the inferior surface of the medial malleolus. This is the tip. This is much more posterior point. Okay. So unless you know that palpation, so if you always miss that. So that is basically it's a bony cause of that is pes valgus deformity. See, almost there is no calcaneal relationship. Talus is completely going down. That is not visible at all in the lateral film. That is going. That is completely subluxated medially, isn't it?
Yes, sir.
So that is the cause of significant pronation deformity, isn't it?
Yes.
So how do you manage the case? So, Chinmada, will you discuss the management or will go to the next case? I think there are much more cases are there. Clinically, I think.
No, let me point out, because I just came to know about this case some time back. It is a very, very rare entity, number one. Very, very rare entity.
Yes.
I was just finding out while, I got the information about 15 minutes back that the biggest study of this was done about 4 years back, which was done over a 4-year period. And out of 1,029 cases of osteoarthritis, only 3 were found here. And out of that, only 2 were congenital, like, something comparable to this. And one was because he had a upper end of tibia fracture, and then plate was put and graft was put, and, raft screws were given. So that was a post-traumatic thing. So congenital superior tibiofibular syndesmosis is very, very rare. And its main problems are that it has, at that point, there's not much of a problem, but it causes a lot of problems in the ankle, as this one is surely going to do.
Yes.
So an answer is not provided properly in any of the literature, but basically there is a suggestion of fibulectomy. I don't know why that should be, but in this case, at the age of 13, it's already looking a little hopeless. So something has to be done. So I would invite all of the panelists to suggest what can be done in this case.
Now it is for symptomatic. Yes, please. For the symptomatic relief, I think what is the age of the patient?
So 13 years.
13 years. So basically what happens here, it is that the tibia is much more elongated than the fibula. So tibia fibular mortis is completely deranged actually. So there is complete tilting of the talus, what I can see that. So I think as it is a bilateral one, so in that case there are two possibilities. I think there is either shortening of the tibia or lengthening of the fibula is very difficult. I don't know. It may be shortening of the tibia or correcting the alignment of the ankle is much more important to be think of. This I think.
But can it be because he's already about 4 years from full maturity? Do you think that doing one such procedure would be enough?
No,
Or
no.
do we wait for a later time and do it,
There may
go on with?
That
It
is
may have to be done again. Because here the need is to protect the ankle, isn't it, Anando? Ultimately, the need is to protect the ankle.
Yeah.
Because you're already having ankle pain.
Yeah, so ankle is ankle is symptomatic. We have to concentrate on the ankle. See what happens. The up to the tibial side is growing. Tibial side is already it is continue to grow, and the fibular is I think it is lagging back. So we have to either we have to short the tibia and also fix. We have to as it is direct epiphysiodesis. We have to done on the lower end of the tibia along with the shortening. So I think that can be useful for correcting the alignment of the ankle. It should be done as
It's vaguely like a menus valgus, isn't it?
Yeah.
It's vaguely like that. But because of the weight bearing joint, you have to take early and definitive pressure, steps to correct that.
Right. Anando, can I make a suggestion?
Yeah, please.
Yeah. I'm sorry to join in a bit late.
Yeah,
but
please.
first and foremost,
expert opinion. So we are like,
first and foremost, this case being a very rare case is a little too much to expect from the postgraduates regarding the management.
Exactly.
So if they can come to a diagnosis and identify that the pathology is mainly in the ankle, I would be happy with that.
Exactly.
Secondly, as you rightly pointed out, his clinical examination, he missed the fact that the malleoli were not at the correct orientation. So I think that is a point which needs to be stressed more. As regards the management, what can be done is, let us concentrate on the principles from the postgraduate's point of view. You have a short ulna, you have a short fibula, you have an overgrowing tibia, you have the ankle in valgus. So before you decide whether you want to do an epiphysiodesis or you want to do an osteotomy, you need to see how much of growth remaining he has. To assess that, because he's a boy, you will need to do an X-ray of his hands, and you'll have to do an X-ray of his elbow, so that from the Sovergrain method you can calculate how much bone growth remaining he has. On the basis of that, you can decide whether he would benefit with a osteotomy straight away or whether he would benefit with a epiphysiodesis type of procedure. Now, given that fact, the options for you are either you can do a distal tibial epiphysiodesis, you can combine that with a supramalleolar osteotomy so that you get a one-time correction of the deformity and you prevent its progression. The other alternative is you can do what is described as a Langenskiöld procedure. That means you can cut the fibula just above the syndesmosis and you can convert it into a synostosis, and you can combine it with a supramalleolar osteotomy in the tibia, and you can do a one-time correction. But you will need to know how much growth remaining he has. That needs to be assessed.
Yeah. You're right. So I think it is a very extensively examined and also discussed. Is there any other? Yes.
Ananda.
Yes, please, Chinmadav.
Some points.
Yes, please.
Number one, in case of lower limb, the growing end is actually the upper end of the tibia.
Exactly.
Yes.
So if you think of the epiphysiodesis, it should be the upper end. But I think before you going for such lengthy procedure in these common cases, actually the 13-year means is adolescent growth part is over. It is very unlikely the patient the deformity will increase very much. So we try the conservative method by modifying the shoes first. By shoe, because he has said that it is a flexible valgus deformity. So modify the shoe and see whether there is an improvement agent or not. If it is acceptable and within the limit, we should not proceed further, because I have already said it is so rare, because we cannot do an experiment on this growing child in case of lower limb particularly.
Okay. Okay, sure. Maybe
I beg to differ on that one, Sin. But I think we should not discuss this on this forum. It's for the postgraduates. This is beyond their level.
Yeah, we're right.
True.
I think we can move on to the other
case.
cases, and this can be discussed in a clinical meeting. I think
Yes,
this
definitely,
is
definitely.
better.
Next case.
Mustafa, please ready with your second case. Dr. Mustafa.
Oh.
Are you there?
Yes, sir. Yes, sir.
So, can't you stop sharing first?
1 second, sir.
Manifest yourself. Abirbhav.
অফ শেয়ারিং করতে হবে, নালে ও মুস্তাফা করতে পারছে না। স্টপ শেয়ারিং করতে হবে প্রথম ফার্স্ট স্পিকারকে।
কন্তিও।
হ্যাঁ স্যার, এক সেকেন্ড।
কোথায় শেয়ার করব?
Right.
Now Mustafa makes an appearance.
Share screen কর।
Just while we are waiting, there is one way I think we can assess that the COVID period is over, which is when in all these Zoom meetings or whatever kind of meetings, everything goes without a glitch. Then we'll know that Corona is gone.
Just a minute, sir.
Yeah.
Good evening, respected sir. I'm Dr. Mustafa Ahmed from third year resident of KPC Medical College. Here I'm going to present a case, sir. A male baby, Mr. Subhash Haldar, age 3 months old, brought by his mother in our OPD with complaint of fullness around and over the right scapular region, right shoulder region from last 3 months, which was painful on handling while giving bath or dressing. Otherwise, the child was comfortable. Baby was apparently normal after birth, but about 2 weeks later, she got a low-grade fever, which was on and off in nature, and fever was not associated with accompanying respiratory, gastrointestinal, and urinary symptom. After subsidence of the fever, the child get irritated and Am I audible, sir?
Yes, you are audible.
Yes.
No, yeah.
Continue.
Yes, sir. After the subsidence of the fever, the child get irritated and the swelling, and the mother noticed that there is a small swelling which develops over the right scapular, right shoulder region, which was insidious in onset and gradually progressive in nature. Later on, she took pain medication and the pain was subsided, but the swelling was gradually increasing. Then after, he consulted so many doctors, but the swelling was gradually progressive in nature, and he came to our OPD for further management.
Mustafa, your slides are not moving.
Mustafa, full screen kore de.
Full screen.
Sir.
Yeah, full screen kar do.
Yes, sir. full screen.
Niche.
First you have to change your enable editing, otherwise you will not be able to do. First to change the enable editing.
Enable editing. Sir, this is the clinical picture which the patient came with us.
It is not moving.
It is not moving. So slide
Press
share.
Slides are not moving. You need to enable the editing option. Click on the enable editing.
And then press F5.
Slide is not moving at all.
Can you see the enable editing above your slide in the yellow bar?
No, sir, I can't see that option.
See the top of your screen where there is file, other menu written, those tabs are there. Below that, a yellow bar is highlighted. On that, there is a button which is showing enable editing. Please click that.
Sir, I can't find any.
Okay, you just put the escape button. Yes, click on the enable editing. Yes.
Now go back.
Answer.
Yeah, fine. Good. Proceed.
Yes, sir. Where is the clinical picture? Just a minute, sir. Sir, this is the clinical picture which the patient came. Along with the patient came, sir.
Okay.
Sir, upon examination, the baby was alert, conscious, and sir, am I audible, sir?
Yes,
Yes, you are audible. Proceed.
Yes, sir. Sir, baby was alert and conscious, but have an anxious look, sir. And sir, vitals are stable, sir. Only there is a low-grade fever at the time of presentation. And sir, there is no short neck. There is no shortening. There is no waving of the neck, and hairline at the hairline. There is no low hairline. Both the interscapular, both the medial border of the scapula and inferior angle of the scapula are at the same level. And sir, this
is a diagnosis. What is a diagnosis?
Sir, is a idiopathic swelling. This is idiopathic swelling, sir.
Where?
And so idiopathic swelling over the right.
Swelling, inflammatory swelling, neoplastic swelling.
Sir, it is an idiopathic swelling. Maybe sir, it may be sir neoplastic origin. Maybe sir, be infective origin.
No. First, see. This is a patient presented with swelling, isn't it?
Yes, sir.
So, what are the questions coming to your mind? It may be a soft tissue swelling. It may be a bony swelling. Okay.
Yes, sir.
It may be infective swelling. It may be neoplastic swelling, or it may be a post-traumatic bony
sir,
swelling.
There is no history of trauma, sir.
Okay, but there is history of infection.
What sort of trauma would you expect? What sort of trauma would you expect?
Sir,
birth injury.
Sir, yes,
but
sir.
You said it appeared after 3 months.
No,
So
sir. It appears just after 15 days after birth, sir.
Okay, 15 days after birth. So did you ask about the birth history? What
Yes,
was
sir.
the method of
Yep.
delivery?
Yes, sir. Baby was born after full term through normal birth, sir. Normal vaginal delivery.
What was the presentation?
What is the swelling? Is it a soft tissue swelling or bony swelling? If it is a bony swelling, from which bone it is coming? At least that information you should tell that.
Yes, sir. It comes from, sir. It is a bony swelling, sir. It is a bony swelling comes from the clavicle, sir.
Okay. Okay. How to know it
See,
is a clavicle?
Mustafa, let me put it this way. The examiner, we are talking about this as an examination. The examiner is, not supposed to, take things out bits and bits. So once you're asked what is your probable diagnosis or what is your case, doctor, you just cannot finish with the idiopathic swelling and nothing else. So you have to, put in some words there. From there, the examiner will go to the next step. But don't expect him to, like take you along the way so slowly because he'll get irritated. You just cannot say an idiopathic swelling, not even mentioning where it is. So we have to question about from whether birth is connected, whether they were.
Complete
You
your
have
diagnosis.
to speak a diagnosis.
Sir,
So
it is
you're giving another chance. Let us start afresh. Doctor, what is your case?
sir.
Meaning that what sir is trying to ask you is from your history and your clinical examination, what is the diagnosis which comes to your mind? Is it one single diagnosis, or if not, do you have at least 1, 2, or 3 differential diagnoses in mind? So based only on your history and examination, please give us your differential diagnosis.
Sir, based upon the history, there is no history of trauma, sir. It may be due to, sir, infective origin or neoplastic origin, or due to uh, uh,
No. Please don't be biased. I'm a guy. I'm helping. So first of all, we identify the bone where it is coming. So what is the bone is affected?
sir, it is the clavicle which is affected.
Clavicle. So how to identify? How do you know it is a clavicle? I'm telling you it is not clavicle. It is from the scapula. It is from the acromion.
Yes, sir.
So how to prove you that you are right?
Yes, sir. Sir, as after measuring movement, sir, there is no problem in the flexion or extension. But when there is a overhead abduction, sir, then baby gets irritated and starts crying, sir.
That is not your answer.
That is not the answer.
That is not the answer.
That is more likely to happen with acromial problems.
Yes. Hello.
Sir, upon palpation, there is a thickness which is found over the clavicle, sir.
Right.
Where?
Sir, which is over the right clavicle, sir. So upon palpation, right clavicle is thickened and broadened, sir.
No, the whole of it.
Yeah,
The medial side,
extent,
lateral, the whole clavicle.
Almost whole of the clavicle gets thickened, sir.
What was the overlying temperature?
Sir, overlying temperature is, sir, not much raised, sir, but bit raised.
Is it raised or not raised? Nothing
Not
like
raised,
much.
sir. Not raised.
Okay. Is the skin stretched out?
No, sir. Skin is freely mobile over the swelling.
Yeah, stretched out.
Any lymph nodes?
No, sir. There is no lymphadenopathy. There is no clubbing. There is no icterus, cyanosis, or lymphadenopathy.
Not important.
And swelling is firm and mildly tender and fixed to the underlying structure, but overlying skin is free and mobile and with normal looking.
So on the basis of these findings,
proceed, please.
Yeah. So on the basis of these findings, what are your differential diagnoses?
Sir.
Or at least what pathology are you thinking in terms of?
Sir, my differential diagnosis is, sir, it is a case of osteomyelitis, or it may be a case of, sir, any tumor or hypervitaminosis A or scurvy, sir, or is a yes, sir.
Infection, you are saying, is it partially treated? There
You
is no
said it wasn't
sinus, there is no discharge.
Sir, from the history, the child was hospitalized for many times, but it may be partially treated, sir.
So these four things which you have said, what are the positive points which you think are there for each of these four diagnoses?
CME হচ্ছে দেখো online.
And what are the negative points?
Yes.
Sir, as the patient has not toxic look and the vitals are stable, only there is a low grade fever and appetite was good, and there is no swelling or scar over the affected area. It infective cause get ruled out, sir.
You can rule out infective cause just like that?
No, sir.
No, you cannot.
Sir,
it has to be kept as a differential diagnosis.
Yes, sir. Lab report also not support
no. Forget the lab report.
We are not coming to lab. Just history and clinical examination.
We are not discussing X-ray also here, just clinically.
If you are thinking in
can it be a malunited clavicle fracture?
Absolutely.
Sir, as there is no history of trauma, no history of trauma, sir. Then
what is the mode of birth history?
I asked you what is the presentation at birth.
That is what Anirban had asked. Yeah.
Did you ask the history? What was you said normal vaginal delivery.
Yes.
Was
what
it a
was
breach?
The presentation? Was it a breach?
Even clavicle fracture can happen during the child birth. It is very, very common, isn't it?
Sir.
So even during the forceful the dragging during the delivery, or there is crash between the shoulder, there's a possibility of clavicle fracture, isn't it? And
Did
the
you
2
ask
week
for
time
history
very
of
much
shoulder
sufficient enough.
dystocia?
Yes, shoulder dystocia, any difficult delivery that may lead to fracture clavicle, and that lead to there is malunion or huge callus, because there's usually huge callus develops in
huge callus.
Yes. Think the common things fast. Don't jump, as you have already showed. We have already see the radiograph. Don't jump into the diagnosis. That is very bad impression for the student. Okay, what is the common thing should be think commonly.
So one is trauma, one is infection.
Yes.
Next.
Other is, sir, congenital anomaly, sir.
Before we move on from infection, do you think it is an acute infection, or it is a chronic infection, or is it a subacute infection?
Right.
Yes, it is very important to differentiate.
Yes, sir. Sir, and there is no sign of acute inflammation. No sign of inflammation is present, sir.
Okay, it's not acute.
Yes, sir.
Okay.
Yeah.
Has the child received any antibiotics before presenting to you?
Sir, history suggests child received antibiotics, sir.
So then will you still get an acute finding? You are likely to get a non-acute situation.
Yes, sir.
So in a non-acute situation, you will not get all the features of acute infection, but infection may still be there.
Yes, sir.
So basically there are two diagnoses. One is malunited clavicle, another is the osteomyelitis.
Right.
It is a chronic osteomyelitis, which is common. Second one is subacute osteomyelitis, but that is rare. Okay.
Anything else you can think of with these findings?
Yes, sir. Congenital only, like, sir, is a springal shoulder may be there.
But you said there is a clavicle swelling.
Prangle is a scapula. You told in your clinical history that the scapula is at the same level, inferior border is the same.
Yeah, neckline was not this thing. Yeah, all these things you ruled out.
Another thing you're saying is hypervitaminosis A, which is, too much of a thing here. So don't say that, because that will create a bad impression.
Yes, sir.
Springal shoulder is way out of line again, because you are, most categorically you are saying that the whole thing is in the clavicle. So springal shoulder is a different thing altogether. So I think, don't we all that we should stick to subacute infection or trauma at the present time without any other.
Yes, sir.
Then, Ananda, anything
Yes.
else you want to
No,
clarify here?
clinically,
At-
there is the
yeah,
right way. There are
clinically
two
these
diagnoses. One is I
Huh.
already told. It is a malunited clavicle fracture, or it
Yes.
is an infected swelling. Most probably, it's a chronic osteomyelitis, or it is a subacute osteomyelitis. Of the
Masked by antibiotics given
masked by
during
masked by antibiotics. That's
yeah,
all.
yeah, I can just add the only other thing you can possibly keep in mind, which is as a third differential, is a neoplasm. Neoplasm in the small flat bones,
Yeah, there is a
neuroectodermal
metaphyseal
tumors.
dysplasia. Metaphyseal dysplasia that can very rarely can happen in the clavicle.
And neuroectodermal tumors. That's the only other differential you can think of.
Okay. So carry on. What is the next?
Sir,
Next.
we have done a X-ray.
Yes, show the radiograph.
Yes, sir. Yes, sir.
Yeah.
Describe it.
Sir, it is a AP radiograph of the, sir, it is the AP X-ray plate of the chest, which shows the both the clavicles, upper end of the humerus, and the coracoid process, and the ribs, and with the cervical spine. And there is a thickening of the clavicle, right clavicular area. There is a thickening of the right clavicle, and there is a periosteal reaction also.
Okay. Where is the periosteal reaction?
Don't find any periosteal reaction. It's a diffuse swelling of the clavicle, more likely. There's no periosteal reaction.
If you stretch your imagination, the lower part of the clavicle, perhaps, but that's quite a stretch.
On the lateral side, okay.
Yeah.
But you can't describe it as periosteal reaction.
Not a classical periosteal reaction.
So a huge expansion of the corticomedullary, huge corticomedullary expansion of the clavicle, whole of the clavicle. That is the basic diagnosis, a basic description. With unable to differentiate the corticomedullary differentiation. That is the basic thing you can no significant periosteal reaction you can appreciate.
It's more, homogenized ground glass kind of a thing.
Yeah, exactly.
You can't really make out the the inside outside, not that way, not cortices, nothing. It's a homogenized swelling. It's a ground glass appearance.
Yeah, towards the lateral end, you can make out the lateral end of the clavicle and some new bone forming from there. So that is fine. It's a diffuse swelling.
So diagnosis is basically it is a chronic osteomyelitis. Maybe it is a pyogenic or it may be viral, as you can already know that. So this is infective disease actually, infective disease of the clavicle. Okay, carry on. Just finish it. So.
How would you, looking at this,
the question is,
what
it is
other...
it is an infective disease now. So as a history of high fever, there is a discharge in the previous.
Right. Fracture is ruled out completely.
Fracture is completely ruled out, and now
sir, at the time of presentation, sir, there was no fever, sir. At the time of presentation in our last OPD.
Naturally, so if it is a chronic, there should not be any fever.
Yes.
Now the question is whether it is a pyogenic or else. Now how to differentiate this?
Sir, I will do some investigation, like, sir, complete blood picture, sir. Then, sir, it is not.
Tell, at least tell.
Yes, sir. There is increase.
Positive findings.
Sir, only there is the increase erythrocyte sedimentation rate, and there is increase platelet count, sir. But sir, CRP are within normal limits, sir.
So total count? What is the total count?
The total count was, sir, just 13,000, sir.
13,000.
Yes, sir.
So do you think it is a normal or more? Normal or abnormal?
Sir, it is abnormal, sir.
So tell
why
that.
is
So,
saying
why not telling?
Anything else you checked? You said in your differential diagnosis that you were thinking of hypervitaminosis A and scurvy. So did you test for any of these two?
Sir, actually not, sir.
Then how do you put it in your DDs? If you are thinking and presenting it as that, you have to either mention it or not, that I have done these investigations, or you should
don't
not
bring it up at all then.
Yes,
absolutely.
Achha,
Now
and
the
CRP, again you're saying CRP. How much was CRP?
Sir, it is actually, sir, 4.5.
Normal.
Within its normal limits. Okay.
Okay. But don't say 13,000 is within normal limits.
Hello.
Because the patient is already maybe getting antibiotics, so 13,000 is high enough not to, call it within normal limits, right? So next.
Okay. So this sort of exuberant periosteal reaction is commonly seen in which conditions? Or which other conditions do you know of which gives this exuberant periosteal reaction?
Sir.
So if you show this X-ray to the radiologist will say there is periosteal reaction, fine. But what are the differentials which cause this amount of periosteal reaction?
Hey,
See, let's put it this way. Do you think it looks like an ordinary osteomyelitis, chronic osteomyelitis?
No, sir.
It doesn't look like it.
Yes, sir.
So what can this be? Or if it is osteomyelitis, what other sort of osteomyelitis might? Or what other pathogenic entities it might be?
Actually,
see, we know that you know the diagnosis. There is what you have already shown us, that this is an entity called Caffey's disease, which is separate, which is a separate identity. But that cannot come out as your answer on the basis of this X-ray and this history.
That is where the disaster is. He knows the diagnosis and he's tailor-making everything towards that diagnosis.
No. But he's not even tailor-making it. So then he can now, at this present moment, he can say that he should say, I think, or we all should say, that this is maybe suggestive. No, it's infective, but there is a strong suspicion of this being a Caffey's disease, because it's, that golden period or whatever. I think Anirban can tell that better. It is within the first 5 or 6 months. And the presentation is very much similar to that. So he has a strong suspicion of Caffey's disease, then he proceeds for that. So skeletal scan should be done.
You are right, absolutely right. Just I have to mention that. So clinical examination is very important, and the most important advice for the student is don't see the radiograph, don't know the diagnosis. I am telling, it is absolutely guaranteed that it will go against you.
Yes.
Absolutely, it will go against you. Don't see the diagnosis. Don't ask anybody. See, see, this is the clavicle swelling. Clavicle swelling, you have to understand in your examination that whether it is a traumatic swelling, it is an infective swelling, or a neoplastic swelling. So if it is suppose how to identify it as a traumatic clavicle malunited clavicle fracture. So there is a swelling, localized swelling of the clavicle, isn't it? But if it is a neoplastic swelling, or it is a infective swelling, that is chronic osteomyelitis, that is a diffuse swelling almost whole of the clavicle. So we have to, if you palpate the clavicle properly, so if you easily understand, there is a whole of the clavicle is thickened, which is the case in this case. So traumatic callus formation cannot extend whole of the clavicle. but that can happen in neoplastic or infective. Okay. Now, how to differentiate the neoplastic and infective? Now, in infective case, it will easily understand the tenderness. If you palpate properly, then you can elicit the tenderness. But if it is suppose a neoplastic as it is a neuroectodermal tumor, or it is a metaphyseal dysplasia, and generalized metaphyseal dysplasia. In that case, it is absolutely painless, isn't it? So the simple examination, whether it is a swelling is a localized or diffuse, whether it's a tender or not, and is irregular. And irregularity is also another feature of some neoplastic disease, which is not usually seen in chronic osteomyelitis. Okay, so this is a simple investigation examination. You obviated the investigation. Why? You know the cause. That is absolutely against you.
If the examiner leads you to that, if the examiner gradually leads you to that, then that's another thing. But if you know the diagnosis and it becomes pretty obvious, that really creates a bad impression. There's no doubt about it.
Don't go for an exotic diagnosis. Stick to basics. If you give an exotic diagnosis, even if you are correct, you will probably be penalized.
Right.
Absolutely.
Next case.
Not next case. I would say, Ananda or Anirban, tell us how should he proceed with this? I mean, he just says these and then...
Yes, it is very important to
he stops there. He will let the examiner lead to some other place if he wants to, isn't it?
Yes,
that's what you're saying.
Are, how to examine the clavicle? Can you tell, please, how to examine the clavicle?
Yes, sir.
Yes, please tell the steps of examination of clavicle.
Yes, sir. First of all, I will tell the patient what I am going to do and what the patient required to do. After proper exposure, I will take a verbal consent. Then I will expose the patient Then I will start first. Then I will start inspection from the front, then from the above, and then from.
Continue, please.
Yes, you're right. From front, from back, and from over the top.
Yes, sir.
So you have to examine the symmetry of the both the shoulder is most important.
Yes, sir.
There are some normal elevation and depressions around the shoulder. Okay,
yes,
and so we have to see the symmetry of the elevation and symmetry of the depression. Can you tell what are the elevations and normal elevation depression of the shoulder quickly? So you have to start from the midline. So midline going down, going outward, and again you will meet both your finger will meet at the midline on the back, isn't it? From the midline from the front, you will start your palpation and you're going from the back, isn't it? So what are the normal elevation and depression? Tell quickly. So first I am telling suprasternal notch. Okay, that is one. Second, there is a depression. Next, elevation. Suprasternal. Next is elevation. There is a one elevation.
So as you move laterally from the suprasternal notch, what
do you get? Sternoclavicular joint.
Exactly. So the joint is elevated. Then
every step you have to see the symmetry. Suppose there is a sternoclavicular dislocation. So in that case, you will get the asymmetry. If you palpate on both the finger on the both sides, isn't it? So first is suprasternal, then the sternoclavicular, then coming along the clavicle. Along the clavicle, you can easily palpate the clavicle. Then, okay. So this is the way of palpation of the clavicle, isn't it? Next is
also as you move a little, particularly because this is a child, you have to see the sternoclavicle muscle, the attachment of it. If there's any abnormality in that muscle itself, then you move further along the clavicle. Then.
Next is the temperature.
Yes, sir.
Inspection, then palpation. First is temperature. Next is the tenderness. Tenderness is from palpation. We have to start from the midline of front to midline of the back. So once where your both the finger meet on the back, and that point is the anatomically where it will meet. It is the, it will meet at the D3 spine. D3 spine,
Yes,
isn't
sir.
it?
Yes,
So
sir.
tell that. So D3 spine, because it will go under the acromioclavicular, then the acromion, the
Spine
angle
of
of
the
the acromion,
scapula.
then spine of the scapula, and then we'll go to up to the D3 spine. Okay. So in each part, we have to see the tenderness, irregularity, thickening, broadening.
Yes,
Okay.
sir.
Now come to the range of motion. So you have to see the range of motion of the shoulder. You have to see whether this swelling is moving independently or is moving along with the shoulder.
Yes, sir.
Isn't it? So in that case, if you easily identify whether it is a clavicle swelling, or it may be scapular swelling, or it may be humerus swelling. Next, the 3 bony points relationship on the lateral end of the clavicle. Do you know that 3 bony point relationship? Though it is very difficult for examination in this small child, but you have to keep it in your mind. What is that 3 bony point relationship of the shoulder?
The Codman's method. Yes.
Yes, please tell.
So, what is the position of the 3 fingers in the Codman's method, Mustafa? I mean,
Yes, sir.
so what is that position? I have told several times. So, what is the position?
So thumb is over the
Thumb laterally.
sir. Thumb. Oh, yes, sir. Thumb is over the.
No,
Sir,
coracoid
I-
process anteriorly. Anteriorly, which finger over the coracoid process?
Actually,
Ritik, time is flying away. Please, Ritik, bolo.
So the 3 finger method, the index finger over the tip of the coracoid, the thumb over the lateral end of the acromion, and the middle finger over the acromion process. So you have to check the relationship of the coracoid and this lateral end of the acromion, and whether there is any thickening, broadening, and there is a change in the distance in between these two. You have to check for that.
Okay. So next is the range of motion, and then the measurement. Measurement, which measurement will you check? There are some measurements around the shoulder girdle you have to check.
yes, sir.
What is
It
the
is the-
measurement?
Sir, it is the arm length.
Yes. Carry on, carry on. Arm length, yes. Then the scapulospine distance. The distance between the midline spine to inferior angle of the scapula.
Yes, sir.
Isn't it? Next.
Also, the distance between the spinous process and the medial border of the scapula.
Medial border, yes, and that is also examined during the shoulder abduction. That is spinoscapular, gynoscapular rhythm of movement.
This kind is.
So that should be
Also-
symmetrical on both sides.
Yes, and in your
Yes.
history, since you had mentioned whether there is a Sprengel's elevation of
Yes,
scapula
yes.
or not, so that the distance between the from the midline will give you a clue, and similarly whether the spinous process is at D3 or is it higher up.
Especially in relation with the other scapula.
Yes.
Exactly, exactly. Okay, and the examination and the dissociation, the scapulothoracic and the glenohumeral movement relationship, it is also important.
Yes, sir.
Sometimes what is the relationship of the glenohumeral and scapulothoracic?
Sir, for every 2-degree movement of the glenohumeral joint, there is a 1-degree movement of the scapulothoracic joint.
Okay, can you dissociate? Is there any clinical method to differentiate these two?
How can you suppress the one and do with
Yes.
only the other one?
Sir, standing behind the patient and fix the scapula either
Yes.
from upward or from downward. Hold the inferior angle of the scapula and then ask the patient to abduct. If there is a till 90 degree of abduction, there is a movement occurs between the movement occurs at the glenohumeral joint, and after that scapulothoracic movement starts. At that time, inferior angle of the scapula moves outward.
Exactly. Okay. Okay. You're right. So these are the points. And next, lastly, the neurovascular reticular endothelial system.
Yes, sir.
Special test and some special test should be done for the shoulder stability and the neurovascular reticular endothelial system. Okay. So special test doesn't have any scope for this small child, and the neurovascular system, the reticular endothelial system is most important. Okay, neurological examination, vascular examination, and the lymph node examination.
Yes.
So that will complete the examination of the scapula, the shoulder. Okay, Abhijita, anything else?
No, I think it covers it all, but I think there is a question of, the examiner in this particular case would really go in for a differential diagnosis, because it's even for the examiner, it's not so very common. How many CAFEs have we seen individually?
Exactly.
So let me put it
question.
Let me put it this way, that we all know that the examinee has the X-rays beforehand. Okay. So he should be particularly very well prepared for that. That is what I'm asking. Not suggesting it himself, but if the examiner is, kind of leading him to it, then he should go that way.
Exactly.
Yes, Abhijit, I'll answer that query for you. Now, as an examiner, like Ananda also mentioned, our point would be to find out what is the differential.
Right.
Now, looking at the X-ray, now I will want to ask him what are the causes of periosteal reaction which he knows of, apart from just fracture and infection. So at this point, if he tells me that, sir, exuberant periosteal callus can be seen in scurvy, it can be seen in an entity called Scafie's disease, that is what is the examiner is looking for. And surely nobody is going to ask him the management of Scafie's. The discussion will go purely on other aspects, like, okay, what other investigations would you do? What are the relevant things? So just because it is a rare case, the candidate does not have to feel fearful that Scafie's disease is something which is, I have never read in Campbell ever, and now I have got it as a case. So I'm definitely going to fail. That doesn't happen.
Sometimes I would think it goes as an advantage if you have a very rare case, isn't it?
Exactly, rightly you are. But if the student can tell it is a case of chronic osteomyelitis or any infective swelling of the clavicle of the affected side, on the right side in a 3 years old baby, that is sufficient for
sufficient and elucidate all the right methods of examining and everything. Exactly. That is sufficient. Then it comes to other things, right? Yes. Okay. Two very nice, very, very rare cases.
We have one more case also. We have one more case. Shonavo,
yes,
are you ready?
Yes, sir.
So start.
Hello.
Yes.
Can you hear me, sir?
Yeah.
I can hear you, but can't see you.
Your screen. A very good evening, all the professors. I'm presenting the last case of the day. I have a video of the clinical examination, so I'd like to share it.
You can't see your screen. Yeah.
So just a second, I'm sharing it. So is it visible?
Yes.
Okay, I'm playing it.
So audio is mute or?
So you can hear the audio?
No, not in the video.
Oh,
not in the video.
Yes. Sharnabo, what you do, I think, is turn the video on and go on speaking as if you're on, on the video. Yeah. So we can have both of these.
But there is
Yeah,
audio.
give us a voice
I'm
over.
just trying to.
But the video is not moving also.
So now?
Right.
Yeah, video is moving.
Video is okay, but audio is mute.
So you go on with the audio of your own.
Give us a voiceover.
Yes, sir. So this patient, he is a 31-year-old male. He came to us with a multiligamentous injury of the right knee, which was caused due to a motor vehicle incident. And it's a 4-month-old reduced post-traumatic dislocation of the knee, actually. And he also had a concurrent fracture, open fracture of the left tibia, which was managed with an external fixator, which is still there. Since the patient, and it was treated outside, since the patient did not come in for a review or even did not follow up with the hospital where he was treated before, we got him after 4 months with the external fixator on and chronic multiligamentous injury of the knee.
Yeah.
So, sir asked me here, what are the findings that we see in this particular case? And so this will be better with the audio, but I described that there, I have done the test for the ligaments.
Tell the diagnosis first, Shonavo.
Yes, sir. This is this is a multiligamentous injury of the right knee in a 4-month-old reduced post-traumatic dislocation of the knee without any neurovascular complications, and there is also a concurrent open fracture of the tibial diaphysis, which was treated with an external fixator outside.
That was in the left knee.
That was in the left leg, sir, but our point of interest is on the right leg.
Yeah,
right knee.
clarify that.
Yes, sir.
The points in favor of your diagnosis, please tell. You have to tell the multiligament knee injury.
Yes, sir.
Reduced knee dislocation. So points
Yes,
in favor of your diagnosis.
Points in favor, sir. Yes. So we examined the knee for the different ligaments, and we did the varus valgus stress test. We did the Latchman test, the anterior drawer, and the test for rotatory instabilities. And we found that there is PCL laxity, which was like a grade 3 laxity, the soft endpoint. We also had ACL injury, which was grade 3 laxity, but it had a hard endpoint, a definite endpoint. And varus valgus stress test also showed a fair bit of laxity. And
so when the question will be asked, the points in favor of your diagnosis, you should start from the history. So there is a history of significant injury,
significant trauma, road traffic accident.
Yes.
Yes.
Then
he sustained dislocation of the knee, traumatic dislocation, and also a fracture, which is a high velocity injury. And after that, he had to be hospitalized for the management of the same. And where his dislocation was reduced, he was put in a slab, and an external fixator was applied on the left side. And
how
after
was
that,
the dislocation reduced?
So we don't have an account of that because he was treated outside. But he said like they
was it done with anesthesia, without anesthesia?
No, so without anesthesia. They probably did it in the ER. Okay. And put him in a slab. And following that, he was not weight bearing, and he rather is unable to bear weight on his right lower limb.
Okay, we're right. But suppose this sort of cases usually doesn't given in the examination, though still if it is already given, that's a very, very chronic one. Suppose chronic means almost 6 months, 7 months old, then patient has come for you for the exam. That is one practical. Now, if this sort of cases you have got, then you have told it's a multiligamentous instability. Then once you have asked the points in favor, then as it is already asked, there is a significant trauma followed by treatment and then followed by instability. Then you have to enumerate the ligaments which is already gone, and then tell the features points in favor of your diagnosis one by one. Suppose it is ACL, why you have told it is ACL injury, tell one by one.
Okay, sir.
PCL, then one by one. Like that.
So we examined the patient as I'm examining for ACL. We did the Latchman's test, and before doing the Latchman's test, we checked for sag sign for any apparent PCL injury, and we found there was a significant posterior sag, and which was indicative of a PCL injury. Then we did the Latchman's test, and in Latchman we found at 30 degrees of flexion. There is a significant amount of translation, anterior translation, with a definite endpoint. And also we did the same at 0 degrees of flexion, that is an extension, and we still found there is a significant amount of translation, which also signifies that there might be associated injuries of the rotatory components. And also we checked for the posterior cruciate ligament by first of all we checked the sac sign, and then we did the posterior draw test, and we found there was like a grade 3 laxity. There was a significant displacement posteriorly with no definite endpoint to it. And we also did rotatory tests, that is the Slocum test for the anteromedial and the anterolateral corner. There was significant opening in the 30 degrees of external rotation, which showed there was an injury to the anteromedial corner, and also in 15 degrees of internal rotation, which is indicative of the anteromedial corner. And we did the dial test for the posterolateral corner, which was indicative of injuries to the posterolateral corner because there was more rotation, which was evident from the thigh foot angle.
How do you differentiate the posterolateral corner from the lateral collateral ligament injury?
Yes, sir. So in if we do hyperextension, that is recovetum external rotation recovetum test, then if there is
what is the implication of dial test positive in 30 degree and 90 degree?
So in 30 degrees of flexion, if we find the dial test when we compare it to the normal side, which we could not over here, then it is indicative of posterolateral corner injury. And if there is significant, like more than 10 degrees of external rotation as compared to the normal side, then it is indicative of a PCL injury. And if that is both, it is found in both 30 degrees and 90 degrees, then it is indicative of a combined PLC and PCL.
But for that, the pivot shift test, which test should be done first?
We should do the test for the medial collateral ligament. That's the valgus stress test.
Yes, it is. Is it positive?
Valgus stress test is positive. That's why, sir, we did not perform the pivot shift test.
Okay. So enumerate the ligaments which have already injured.
So the ACL, the PCL, the medial collateral, as well as the lateral collateral, and on all probabilities, the posterolateral corner, which includes the oblique popliteal ligament and the popliteofibular ligament.
Okay. So how do you plan for your management?
So this patient is already 4 months old. So considering it's a 4-month-old ligamentous injury, so we will plan for a reconstruction after we have done a skygram, a straight skygram of the knee. Then we can also do stress views, and we do an MRI to first establish our diagnosis, and then we go on for definitive management or treatment of the patient for reconstructive.
Have you managed it still, or waiting for management?
Yes, sir.
Have you managed it?
So yes, this patient has undergone the reconstruction of the PCL as well as the medial collateral ligament.
Enumerate the importance of choice. Which should be treated first, and what should be the sequence of management?
In the sequence by which we treat the or reconstruct the ligaments, the PCL should be reconstructed first, because it is the axis and also it stabilizes the knee for further reconstruction. And then we reconstruct the posterolateral corner, and then the medial collateral ligament, and then the ACL if the patient is very athletically demanding or he has a significant instability after that.
At least the MCL should be, I think MCL should be treated first, followed by the posterolateral incision, the posterolateral corner, and also the lateral ligament. So that is the, I think, and in that ACL, yes, ACL, if it is significant laxity persists still, then you have to till the ACL, isn't it?
Okay.
So there is a clear-cut case, I think, but though it is not very common for your exam purpose, but it is a very clear-cut case, and that opinion is straightforward. Anything, any point to be added from the expert panel?
I think reading of the radiograph and the MRI.
Yes, reading of the radiograph. It is very important. Please show the radiograph and MRI.
So I actually don't have the radiographs because probably the files got corrupted from the person who took it. I'm sorry regarding that.
You have the MRI here?
So actually the MRI and X-ray were both in the same folder. So I kind of don't have it.
Do you remember something significant out of the context we were talking about? Something else that was there?
So like a bony injury or anything?
Okay, let us ask you something
I'm
else.
talking about cartilage damage. How much of that was there?
Sir, when the diagnostic arthroscopy was done, there we did not find an evidence of significant cartilage damage or osteochondral fragments in the joint.
Okay, you said you wanted to do a plain radiograph. What all things you think can be associated which you would see on the X-ray? Clinically, you establish it's a multiligamentous injury.
Yes, sir.
You also said there was a history of a dislocation. So
yes,
on the X-ray, what associated injuries would you have can be found?
So there can be an avulsion fracture of the fibula where the LCL is inserting, and also there can be a fracture, avulsion fracture of either of the tibial spines.
Okay.
For the cruciates, and sir, there can be a fracture of the adductor tubercle. I don't know if that is well visible in the X-ray.
No, not so much. Okay.
And stress radiographs. So should I?
No, stress radiographs. I mean, if MRI is available, then I don't think it is advocated anymore.
When there is a confusion in MRI, if it is the PCL is torn or not, so if there is any confusion, you can do the stress radiograph for PCL and PLC injury by kneeling. By kneeling radiograph, you can measure the posterior translation of the proximal part of the tibia and compare in with the normal side and see. So this is the significance.
Okay, one other question. Suppose this patient had come to you immediately when there is a dislocation.
Yes,
how would you have managed it?
So in a traumatic posterior dislocation, first I would assess the vascular status of the patient because usually the popliteal artery is at risk, and neurovascular assessment should be done. Yes, sir. Also, we check for foot drop, any involvement of the counterrenal nerve, and if we find that there is any neurovascular injury, then we have to proceed likewise, and then so for vascular injury, if there is palpable pulse which is comparable to the other side in volume and rhythm, then we proceed to try and reduce the patient the limb after sufficient analgesia. And if not, then if the ankle brachial index or the angiogram, if it is suggestive of a vascular injury, we proceed likewise for first the vascular reconstruction or insufficiency, so that hello.
Yeah.
Yes, sir. So we first try and improve, or we try to make sure that the vascular sufficiency is there. After that, we move on to the treatment for the knee dislocation. And in the acute setting, we don't do any arthroscopy because there might be capsular rents which can cause fluid extravasation. So we wait and wait for 2 weeks till the capsular rents are all healed up, and then we do an arthroscopy and we can try a repair of the ligaments in that in a 4-week setting, within a 4-week setting.
Okay.
Okay, fine. I think it is well covered. So is there any other case?
So I was the last presenter.
Okay.
For the case actually. So should I stop the screen share?
Yes, please.
Okay, any comments from the expert? So the cases are well, very interesting enough, and it is well covered. There are ligament injury, one is infective, another is congenital abnormalities is very rare. So basic message to all the PG postgraduates. So don't jump on the exact diagnosis. So you have to go by your the systematic way. You have to examine. Once we have see the patient. So always try to categorize whether it is a traumatic, infective, inflammatory, neoplastic, like that. So once we have categorized that it is a traumatic infection, then come to the diagnosis. So whether it is a soft tissue problem or is a bony problem, then what is the functional deficit? There may be multiple functional deficit. So if there is a multiple functional deficit, you have to prioritize. Which, suppose it is a case of VIC. So in that case, you have to prioritize which function should be given the priority. It is a neurological function should get the priority. It is a muscular problem will get the priority, or if there is some joint problem will get the priority, or some skin problem may get the priority. So we have to prioritize happening. Suppose there is an infective non-union with some deformity of the leg. So in that case, there are multiple problems. So we have to prioritize the complaints, functional deficit, and we have to accordingly we have to address that. So first of all, we have to categorize the disease, which sort of disease it is. It is an infective one, so maybe it's a chronic infection, but maybe acute infection like that. Or if it is acute, after all, it is infective. Now try to understand whether it is a pyogenic or tubercular, like that. Okay. So whatever the information you can tell that you have to get from the case, and you have to convey that convey to the examiner. Okay. Now first is the categorization. Next, the which bone is involved, bone or soft tissue is involved. Next, the functional deficit, enumeration of the functional deficit, and then the practice. This is actually the art of practice. If you practice it in every case, so you will be very much expert on this. So okay. Then now the trend is going to become the short cases. Most of the cases are actually examined as a short case. In DNB also, the examination of the long case is already completely gone. Now only the short cases, now it is going to be switched over to OSCE system. Now it is going to become the OSCE system. So in our MS ortho examination also, we are going to become switch over to most probably the short cases. So in short cases, become very much smart enough. We'll always think of the diagnosis. In diagnosis, should not intermingle with the symptoms or findings. Suppose a genuvalgum deformity of 10 millimeter medial malleolar distance. Don't mention that. Then genuvalgum deformity is idiopathic. That is sufficient enough. Okay. If it is suppose it is a symptomatic, so it's a painful ankle. So it is a symptomatic deformity. So let the examiner ask the questions. Which symptoms? What are the patient's symptoms? So if you guide, if you try to maintain this manner, so in that case you can guide your examiner. You can guide your examiner to ask the questions because the answer is already known to you, isn't it? So follow the dictum and tell in such a way that the examiner will ask in the next question is very common to you. Okay. So suppose it's a cubitus varus
তাতে কি
deformity.
খুব
So
ব্যথা
tell it is
পেয়েছে?
a case, patient has come with a cubitus varus deformity. So tell it is a right-sided cubitus varus
গরম
deformity.
জল ঠান্ডা জলটা
Following,
করুন,
what is
কমে
the
যাবে
now
আস্তে
cause?
আস্তে।
There is a malunited supracondylar fracture. Following
হ্যাঁ, খুব
malunited
প্রয়োজন
supracondylar
হলে
fracture, how
খাবেন,
much
চেষ্টা
duration?
করুন না খেতে।
There is a 3 years duration. Okay. So is there any complication? So complication means there is associated some neurological
3
deficiency,
মিনিট গরম
or
জলে
there
1
is
মিনিট
associated
নিজের
some
ওষুধ বসে
restriction
খাবেন।
of movement, or if there is associated limb disturbance. Then tell that complication. Okay.
তাহলে একটা
Next,
খারাপ
identify the side, the right side or left side,
মানে
and
খুব
then identify
হাই
the
স্ন্যাক পি বা কিছু
there
একটা
is a
খেয়ে থাকেন।
male, female,
বেশি স্ট্রং
or
কিছু
what is
না
the age.
খাওয়াই ভালো।
So this is
আমি
the
আসলে
way
নিতে
of
চাইছি না।
presentation in every short case. Okay. So tell like that. So first,
না ওটা আনান না, ওটা খুব প্রয়োজন হলে
categorization, then the which bone is affected. Next is the
একটা
problems,
লাঠি নিয়ে
which
হাঁটুন না
problems. You
কটা
have to
দিন,
prioritize
ব্যথাটা
the
হয়।
problem. Okay. I think it is very, so we will meet in the
ঠিক
next
পারেন,
class
কিন্তু
also.
গরম জলটাই পারবে বলে না।
Thank you, sir. Thank you for the valuable comments of Professor Ananda Kishore Pal, Dr. Anirban Chatterjee, Dr. Abhijit Sarvatikari, Dr. Jayanto Mukherjee, Dr. Bhuvan Pal, Dr. Nilakanti Das. So thank you everyone. Thank you WBA for giving us such a good platform for all the PGTs to interact and for a good scientific session. So we should conclude here. So thank you all.
We'll love to meet again.
Yeah,
Thank you.
yeah.
Yes,
Yes, sir.
sir.
Yes,
All the best to
Thank you,
all
sir.
the postgraduates.
Yes, yes.
Thank you very
Yes.
much.
Thank you, sir.
Thank you. Thank you. Bye.
হয়ে গেছে।